We will start this session. I'm very sorry, but there are so many things going on in parallel, and this is just the first day. So I'm sure all of us are going to be thoroughly confused by the end of the weekend. So, yes, we have Dr. Sujata all ready and glaring at me to start. So, please, clinical guidance and support. Dr. Sujata.
Good evening, everybody. Since we are
Please
just
sit. I know, Ramesh, you don't need any clinical guidance, but
I'm not. My talk was directed towards trainees as well as people who wanted to start a training program on their own. But since all of us have training program, I don't know how much my talk will be relevant. The first, I will be covering my talk on why pediatric ophthalmology and neuro-ophthalmology, what to expect, where to do the fellowship, when and how to apply and structure of the fellowship. Some of it I think will be totally irrelevant. I'll be scrolling through it. So why pediatric ophthalmology? We all know kids' eyes are not miniature adult eyes. So we need specialized training. We have limited exposure in our residency programs to pediatric ophthalmology and neuro-ophthalmology. Then strabismus surgeries require special training. Pediatric cataracts not only requires training, but it is all about the follow-up of the cataract. Glasses in children is different. Some of the residents may like the subspecialty when they're reading different subjects. Some of the residents would like to continue institute practice, and pediatric ophthalmology and neuro-ophthalmology is definitely an important part of the practice. If you belong to a family of pediatricians, you would like to do pediatric ophthalmology, obviously. It is a relatively less saturated specialty, especially in the smaller C towns. Now B towns also have many pediatric ophthalmologies. The setup is less expensive as compared to the retina setups or say cataract. And multi-specialty children's hospital do need pediatric ophthalmologists. So there are always multi-specialty children's hospital coming up, and the need for pediatric ophthalmology is always increasing. So this was this interesting paper published in 2017 Indian Journal of Ophthalmology, which analyzed the prospect of pediatric ophthalmology. It was a questionnaire for the residents of 2013-2014. And some of the results which came up were nearly 70% of them responded that there was no structural teaching or posting in their residency program. And I think it remains almost the same to this date. 60% found that it was difficult to understand the subjects, and only 20% responded that they would like to do pediatric fellowship if they were given a chance. The major attraction was intellectual stimulation and independent operative skills, and the dissuading factors were difficulty in handling children and the stress factor involved. So, why neuro-ophthalmology? Well, it's an integration of many subspecialties. So people with interest, doctors with interest in medicine, neurology, radiology, neurosurgery, who like doing teamwork, and who like racking their brains would like this subspecialty. And you can make life-altering diagnosis in neuro-ophthalmology. So at the end of the day, if you want to go home feeling good that you have altered the life of some patient every other day, so you can actually opt for neuro-ophthalmology. So what should a good pediatric ophthalmology fellowship offer? Apart from how to know how to deal with children, it should give you an extremely important skill of refraction or retinoscopy. And then there should be a training on comprehensive pediatric examination, pediatric and adult strabismus workups. Posting should be given in orthoptics, low vision aid, vision therapies, ROP screening, special children's clinic like cerebral visual impairment clinics, and they should learn how to dispense prisms, glasses, counsel parents. Initially, all these fellowships could have a little bit of comprehensive ophthalmology, and towards the end of the fellowship, they could have independent OPDs. The academic should be in the form of journal clubs, case discussions, seminars, presentations. They should be given research projects, case reports, and allowed to present their research in conferences. Pediatric ophthalmology is a broad specialty, so posting should be given in oculoplasty, retina for ROP screening, glaucoma, neuro-ophthalmology, all should be included in a pediatric ophthalmology fellowship. At the end of the fellowship, the fellow should have a rough idea as to how to set up a pediatric practice, child-friendly outpatient, collaborate with pediatricians and geneticists. And what about a good neuro-ophthalmology fellowship? Well, history taking, that is the crux of neuro-ophthalmology. So they should learn how to take a very meticulous history, learn basic neuro-ophthalmology workup, thorough training in ERGs and VEPs, thorough training in OCTs, bit of neuroradiology, bit of neurology related to ophthalmology, so that they can order appropriate systemic evaluation, because in neuro-ophthalmology, you have to order for a lot of systemic evaluation, and you must know how to tailor it, and of course the academics that I have already discussed. The neuro-ophthalmology should have postings in pediatric ophthalmology, oculoplasty, and glaucoma, and importantly, outside of the ophthalmology, in neuromedicine, neurosurgery, and radiology. Ideal fellowship should have all of this. So when should you apply? Since there are no students, I'll skip over this. A little bit of cataract skill enhancement program. If you haven't been exposed to cataract surgery in the residency, which many of the residency don't expose children to, they can have a short skill enhancement program before they join the fellowship. Some of the states have bonds these days, but these bonds can be postponed till after the fellowship. Where to do the fellowships? Most of the institutes have fellowship programs in pediatric ophthalmology. Most of them do include neuro-ophthalmology also. Like LVP has neuro-ophthalmology as well as pediatric ophthalmology. And most of the programs are 18 months. Some of them, like in LVP and AIMS senior residency, is for 3 years. And you can tailor yours according to your needs. Where to do the fellowship in neuro-ophthalmology? Only Chennai has got a 18 months fellowship. The rest have all short-term fellowship, LVPI and Arvind. How to apply? Well, how to tailor the intake of your students? Most of these institutes have initial MCQ examination followed by Viva. So if you want to run a program, you can tailor your MCQs in the specific subjects and then follow it up with interview. LVP has, Dr. Ramesh is sitting here, they have a graded staged interview process. And you can have 2 sessions, 1 sessions, depending on the need. So how to structure the fellowship? Well, I have given the structure of most of the institutes which have been running these fellowships for a long period. Shankar Nethralaya has a 18 months fellowship, of which 12 months will be with the pediatric ophthalmologist as a mentor. It may not be one mentor, it may be several mentors. Whoever is in the department as consultants will have the fellows posted with them in rotation. And you have a rotation in oculoplasty for a month, neuro-ophthalm for 2 months, retina for a month, and the last part of the program will be as a senior resident, where they get to work up their own patients and offer them surgery, and they will be allowed to do the surgery under the guidance of the mentor. It is a similar pattern followed by Arvind also. They have an initial general ophthalmology posting for about a month, followed by the pediatric ophthalmology. And all these programs will give you a posting in low vision and rehabilitation in ROP clinic for some period of time, in the neuro-ophthalmology clinic if it's a pediatric ophthalmology posting. And most will give you surgical exposures to squint, adults, and pediatric cataracts. LVPI has it a little different. They have advanced in induction module in which initially they will have a basic subspecialty training, then they will be sent to the secondary postings for the next 1 year, and they will come back and will be in the advanced subspecialty training in their own department. If you have to model a structure of fellowship, these things are important, that you must have ancillary posting in low vision, in refraction, cycloplegic, the retinoscopy skills are very important in pediatric ophthalmology. So that is one thing which all candidates should be guided into. Low vision aid postings, postings in ROP screening are very important. To summarize, pediatric ophthalmology has very rewarding prospects. The structure of the fellowship should include all the things I have already spoken about. You can apply after post-graduation, but a short cataract training can be useful in the fellowship, and all major institutes do offer the fellowship. Thank you.
Thank you, Dr. Sujata. It was a wonderful presentation, and what residents and fellows, it was important for all of us to know how we can, upgrade our programs that we are offering in the different institutes that we represent. And I think with FICO also working towards some collective certification and all, maybe we all can probably pool in information and resources and probably try and create a system where we all, especially because there are very few, as you've mentioned, talking about pediatric ophthalmology and neuro-ophthalmology, probably bring about all our pass outs at a rather level so that it becomes good. But thank you very much. I think it was a learning experience for all. Any couple of comments, anybody? Great. So maybe we'll catch up on the lost time. So we have Dr. Shruti, who will be now speaking on surgical skill set enhancement schedule.
Good evening, everyone. So I think we have representation from all the institutes that actually do the training, so it's really nice to see today. Slides. So I'm going to be talking about surgical skill enhancement.
Could we have the slides?
One second. Okay, so for pediatric ophthalmology and neuro-ophthalmology, okay, so the earlier Halstead traditional teaching was to see one, do one, and teach one. So this was the earlier model where we didn't have a really objective way of teaching surgery. So it used to be like the surgeon decides how well the student does, and then they teach, and then they ask them to teach further. So that's how it was earlier, and I think we've digressed a lot from then. Now it's more objective, it's more structured, and it's more towards patient outcomes, and as a result of which, whether knowingly or unknowingly, there has been a downward trend in the amount of squint surgeries that we're actually giving our trainees. It's down from 121 to an average of 43. So this is something that actually has an impact on how the residents feel when they take up pediatric ophthalmology. So this is another interesting article where they acknowledge the absence of structured surgical training and pediatric posting during the residency program itself. So that sets them up for taking pediatric ophthalmology as a career. So it is very important that against this background, we give a good amount of surgical exposure in a very structured manner that gives good patient outcomes as well as good exposure to the trainee as well. So before we begin, we really need to understand and also be ready as a trainer to be to exude confidence, and that's within double quotes, because though we might be laughing outside, it's as a trainer, we know that during surgery, there are so many situations where we are kind of going to be really putting our emotions back and trying to adjust to what is happening there with the trainee. So definitely putting a bold face up is a big thing. Second thing is to allow mistakes to happen, and that's again to go back to our fellowship days as how we were as a fellow, and then to learn from that and allow the trainee to make a mistake and then to learn from that. The third is to be generous and to give a lot of exposure to the trainee in order to learn, including complex cases. The next point is about being fair, which basically means being fair both to the patient as well as to the trainee, because there are some trainees who can be quick on the pickup, and there can be some trainees who can be a little, they can take a little time to train. So in those cases, we'll have to make sure that objectively both get equal good amount of exposure, as well as not compromising on the patient outcomes. And always ensure that you have a good team backup, and that's the secret behind a confident trainer. When you have a good VR backup and you have a good team behind us, and then we have more confidence in training our fellows. So surgical training basically begins in the OPD. So always good evaluation techniques have to be taught in the OPD, and always sticking to protocols, especially when they are getting trained. So 9-gaze measurements is a must, sensory evaluation is a must, doing documentation with photographs is a must. These are basic things that if they don't learn there, they're never going to learn it outside. And of course, learning the concerned diagnostics and the way of arriving at the diagnosis is also something that has to be taught to them way before surgery starts. And final plan of the surgery has to be discussed with the trainee, and optimizing surgery. And by optimizing, I mean if there is to analyze the situation as a whole, the diagnosis as a whole, and if there is something where you can add a component to optimize the surgery, then definitely it should be done, and that should also be discussed with the fellow before going in for surgery. Now, once the OPD is set, then the fellow has to go into a good orientation. So a knowledge enhancement is definitely a part of surgery skill. So they have to know their surgical anatomies, they'll have to know their instruments, they'll have to know surgical steps and the possible complications and the outcomes that can come out of it. So usually before surgery starts, they'll have to end up having a good theory knowledge on it, and usually before surgery, it's advisable to go for one viva on a one-on-one before they start the surgery procedure, so that they know their theory. And when it comes to wet lab practice, does it really help? Yes, because surgery is basically skill. It's a muscle memory. The more the hands work on it, the more the hands get acclimatized to good surgery. So wet labs definitely help, but how does it help, and how can we help it in strabismus? So there are many simulated models available. These are some models which are non-biologic models, but they are a little expensive. We do also have another one that was recently introduced in WSPOS last time, and we had a hands-on experience on these models, and these were good as well. This was another interesting low-cost technique from Dr. Amar Pujari, and you can see that these goat's eyes were used to train for recession and resection, and it worked pretty much similar to the human eyes. So this is another interesting technique. Another one that was recently that I came across is a very simple but very effective technique to teach strabismus surgery before the real thing. So here they use a simple tennis ball, a ping pong ball, and then you put it on a wooden board, and then for the sclera they use foam boards so that it mimics a sclera, and for the muscle they use felt. So it acts similar to the muscle texture. So here you can see this is how they place it. The foam can be placed in 4 strips, in 2 strips across, and the felt can be placed as 4 strips. The good thing about this is that it actually mimics the kind of texture that we're looking at, but the downside to it is you don't get a exposure thing like the tenons, how you dissect. Those are the things that you'll probably not get a good idea of in these models. However, there have been studies that have been done on bacon. So they say that testing it with bacon gives a little more of a tissue separation experience. So these are all low-cost models that can be done. This is another model wherein they used a rubber ball to mimic the sclera, and gloves to mimic the conjunctiva, so just simple latex gloves that can be stuck all around. And also the white bands that you see are the muscles, which are nothing but elastic bands, and they found that to be something similar to the recti muscles. So again, this gives us a good sense of feeling and muscle memory that helps them in training. So these kind of wet lab workshops kind of really help and go a long way in setting up the trainee or the fellow to actual surgery. So before surgery, of course, measurements have to be recorded, photos have to be documented, and the final plan has to be decided before going ahead. So this is just, I pulled out stuff from my logbook from way back, and you can see that the day before the surgery, the trainer or the trainee or the fellow has to sit down and write the entire plan for all the surgeries that to be done the next day. And this is really important because the fellow actually gets to learn what is going to be done, and then that sets them up mentally for what's going to happen the next day. So on the, in the OT, on the initial observation, the day one would probably be just a flow observation, just to see how the flow, the OT flow happens. From day two, I think it's always good to start, for them to start assisting, and first as a second assistant and then as a first assistant. They should know the instruments, handling of the instruments, and how each goes and in which order. During surgery, of course, before they actually start on the patient, they need to be primed. So we need to tell them that you have to stop when the trainer tells you to stop, and you need to listen to the trainer as you operate. And these are basic instructions that have to be given before any surgery starts. And next thing is, there are two ways of doing it: step by step, or going entire surgery at one go. So we always prefer the step by step because they get better at one step, we give them the next step. That it gives them more confidence. We usually start with the conjunctiva, the hooking of the muscle, and of course conjunctival closure, and then slowly as they keep getting better, we can give them muscle tagging, and then finally the scleral bite. And initially it's always good to stay with the fellow completely, and then as time passes by, we can let them do the surgery on their own and then just pop in for the scleral bite alone. Post-surgery, it's really important to do a thorough follow-up. The fellow has to come, remove the patch, do the dressing and see what the outcomes are, and also do the logbook entry. That helps them complete the loop and to see how the change has happened. And then it's also good for them to discuss with the juniors, and that helps them refurbish in their mind and also pass on the information to the next set of students. So this is the ICO Oscar grading for strabismus. It's really, it's an excellent tool for objectively grading surgery outcomes. We can see how each step has grading from, based on the Dreyfus model, the novice, beginner, advanced beginner, and the competent. And then as the trainee advances, you can score them better so that they know how well they're doing. Of course, when it comes to complications, you can't avoid this, globe perfs, under overcorrections, anything can happen. But as a trainer, we'll need to step back and help them do it. So we need to maintain that British stiff upper lip when it comes to dealing with these complications, and not show it to the trainee, and also manage it on the patient side. So definitely advanced strabismus techniques have to be taught to the trainee. Oblique muscle surgeries are definitely, they've become commonplace now. Transposition surgeries as well. And definitely, if not directly operating, at least they can assist complex strabismus syndromes, nystagmus surgeries, and at least a few resurgeries as well. Exposure in these arenas would really help the fellow. When it comes to pediatric cataract, it's very important that the trainee has prior adult cataract surgical experience. That goes a long way for them to, in terms of their hands. So what is recommended is around at least 100 to 200 SICS and maybe around 50 phaco's. That would give them good hands. IOL power calculation has to be taken, and again a viva. It's always good to start with older children initially, maybe 6 or 7 years and above, and then go to younger children. Initially LA plus PCIOL, and then followed by anterior vitrectomy and PPC. And it's always, again, good to give steps very slowly during the initial parts and then take them forward on the advanced steps later. Again, this is another ICO scoring for the pediatric cataract Oscar grading. Again, very detailed. I think this was developed in SN. So the question, how many surgeries can a fellowship provide for surgical competency? There's really no golden number to this, but on an average, about 30 to 40 strabismus surgeries, or around 20 to 30 cataract surgeries would probably form a good exposure to the trainee. And of course, neuro-ophthalmology exposure, posting with the neuro-ophthalmology department, and also discussion with the radiologist. This is another thing that we tend to emphasize. They travel to the radiologist and discuss the scans with them. So that really helps. And another thing that I wanted to add was the post-fellowship services that we can extend to the fellows. That is, one is library services. I think Arvind already extends it. If you're an alumni, you get access to their library with a basic minimal fee. The second is long distance mentorship. So maybe after they leave, the first 10 or 20 cases can be mentored long distance, and that would really help them gain confidence. And the third is, of course, collaborations. Once an alumni, always an alumni. So you get to collaborate with them on multicentric studies. Really, the possibilities are endless. So obviously, a structured surgical program is the way to go. give them good theory, viva, wet lab, logbook, and structured number of cases. So if you're looking to have confident, competent, thorough, and fellows with a sense of adventure, we need to set the basics, enhance the skill set, slowly initiate them into surgery, and follow them through. Thank you so much for the opportunity.
Thank you, Dr. Shruti. An excellent presentation.
Yeah.
Thank you very much. Any comments while I request Dr. Jyoti to come and give a talk on academic equivalent going forward? Yeah.
What do you think about wet lab for strabismus?
So, of course, with Dr. Amar, we had developed this Gotsai thing during the COVID period. And all our residents now, for Squint, all of them have to mandatorily do a fair amount of, these surgeries on the Gotsai before we allow them to operate on the patients. I mean, of course, this is a rule that we have done. We had for cataract for a fairly long period of time. They were assessed, they were scored and marked, and only subsequent to their passing a particular score are they allowed to do cataract surgeries on human eyes. The same, although there is no clear scoring as such, but we kind of directly observe them on their surgical skills on Gotsai before we allow them on patients. Absolutely. Very, 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 very beneficial.
We should approach you and...
No, it's no need to approach us. It's a very simple set. There's nothing really complicated about this. We just get whole globes of goat eyes without them cutting the muscles. So when they're enucleating the globe, they usually were cutting the muscles. We just ask them that they use the enucleation, the spoon, and we cut them at the optic nerve and we remove them with the muscles. So, and then there's just a small contraption. We use rubber bands, kind of bands to, kind of tie the muscles posteriorly onto a clip so that there is an adequate stretch on them. And then the eyes are fixed so that they can operate on the muscles and get an adequate tension to pass sutures, cut, recess, resect, plicate. They even get an idea how to do, transposition, things like that. But of course, it really is not so much as far as the surgical learning there is concerned. But yes, they learn very nicely how to handle tissue and pass sutures. That's what we realize. In fact, that's what we started in COVID times because no squint surgeries were going on at that time. Exactly. So it was very difficult to keep them trained.
Because squints is seasonal. So some batch doesn't get the same exposure as other batch.
True. So in fact, that's why we had evolved this technique. And all our residents, we have of course senior residents. All senior residents found that very useful. In fact, we are encouraging many junior residents who often do not want to continue a senior residency or want to go and do fellowship, are interested in pediatric ophthalmology. We encourage them to give it a shot as a junior resident. It really doesn't take anything but a little bit of time. So
right, sir. Thank you.
Yes, Jyoti, please.
Yeah. Okay. So good evening all. At the outset, I'd like to thank ARC for this opportunity. So I'm going to be talking on academic involvement going forward. So let me start with my journey. I did my post-graduation from KEM Mumbai, which is in around 2000 year, where when I finished my fellowship, I was doing topical phacos and it was comfortable. But at that time, I went for a contactless course to LV Prasad. And I got really floored by the place, and I said, yes, I have to do a fellowship there. And the reason why I decided to do a fellowship, because I wanted to look at academics. So my friends kept asking me, you can start a private practice in Mumbai. You know how to do topicals. What is the need to go? But the reason I felt that even surgically, if I was too sound, there's something missing, and I had to go to this place. So what is academics for me? Knowledge, presentations, publications, training, and communication. And these are the 5 important things which I did not get much exposure during my PG. And I think these are something which as a student you all need to know, and I'll take you through each of them. So starting first with knowledge. You don't know what you don't know until you know it. And this is the major goal of any fellowship. And this is what I realized when I went to LVP. I thought I knew everything. I'm doing topical. What's the big deal? But a lot of clinical skills we don't know. And more so in medical colleges, we are deprived of those opportunities. So with that, that's the first goal. Second is golden opportunity to study during your fellowship. Read books, journals, recorded webinars. Now we have an access to all that. And look for evidence-based medicine. That is very important. Because you need to understand that the eye sees what the mind knows. And if you don't know something, you'll not be able to actually figure out what to see in a patient. And let me tell you, during your fellowship, you can read a lot. Once you are done from that place, you will never open a book unless you have a presentation like this or you have to really present. So take the opportunity, read as much as you can. During your fellowship, watch your teacher examine, counsel, and treat. Discuss normal cases, difficult cases at the end of the day. That's important. Imitate your teacher and learn what to do. But sometimes you should also learn what not to do. So don't always look at the teacher in all aspects. And as a trainer, we have to realize that the fellow who's come is like our child. And we need to really help him grow just like what we are. And that's something which, as trainers, we should do. But at the bottom line, we should know, even if we are ophthalmologists, we should finally aim to be a good human being. The other important aspect is mentor and mentee program, which helps us to improvise on our ability, capability, and helps the fellow sail through very easily. Just like the mentor can evaluate the fellow, we should also have the opportunity for the mentee to evaluate us so that we become better teachers in all aspects. It's the clinical, discuss with the case with your student of how did you do it, your surgical skills, and then it helps us to grow. We cannot assume that we are the best. Many a time, they would have read a little better than what we have discussed with it. So that is how a mentor-mentee program could do. Other important aspects is, yes, trying to get on the social media. There are a lot of groups available. We can discuss more so once you've finished your fellowship. You can discuss and get opinions, learn, to stay in touch with the latest news that's happening, the treatment options available, and meetings. Like, for example, I'm KM alumni, so I'm a part of that group, the LVP Pediatric Alumni Group, and then other groups where we are a part of the pediatric ophthalmology. In the end, you should also think from your knowledge what specific you can do. Something will make you different, like you can choose ROP, you can choose pediatric cataract, you can do strabismus, and as discussed earlier, pediatric ophthalmology with CVI. You can also have myopia, which is now the new kid on the block. And finally, pediatric genetics. So there's so much there, much more than. So in addition to what you do, try to have a niche area, and that will help you grow further. Presentations. The other thing is, during your fellowship, start with case discussions. Difficult cases, how do you diagnose, management options, surgeries, and have a very good documentation, because that can be your first publication by writing a case report. Like, for example, this 6-year-old child, CKD, came and had these classical disc features, which were of a papillorenal syndrome. As I said earlier, if you have not read it, you would not think of it. So it's important that you have read it, and then you can put it as a publication in your journal. Then have more journal clubs, didactic lectures with your mentor. It should be more interactive. Sit with them and learn how to do, because eventually you may have opportunities to present. Newer technologies you should learn, like using the slit lamp photography with your phone, because you may not be able to get an access once you leave a particular institute. The 9-gaze photography apps, which are user-friendly and available. So all of us have, but if you are known to it, you comfortable with it, you can start doing it once you're in your practice and out of this place. Then focus on studies, which is important. Maintain Excel sheets of your squints, cataract cases, morphology and surgical outcomes, etc. Research projects should be there, like in pediatric cataract, myopia, multiple things you can choose what you like. Focus should be on good scientific content. Also, you can beautify your presentation as well to add value to it, especially when you go to present in your conferences. There are so many options of animations, transitions, ready-made templates, tool in PowerPoint, or even Prezi. So all this you can make so that among your counterparts, you can actually stand apart. So this is something which you can do as a fellow, learn all these aspects also. As a part of fellowship program in an institute and for regular classes and meeting, you should have, like in NN, we have our regular classes, we have conferences, so try to present during that. Be member of all societies. So like local society, I'm from Bangalore, so take it from BOS, then our state society, so KOS. And since I'm from Mumbai, so I would also be a part of BOA and MOS. So wherever you have an opportunity, please try to present at those places. Then obviously national conferences, that is AIOS. Then specialty conferences, where we have SPOCI and POSN, which is a new one, where we have all case presentations and all discussed. Then WSPOs and APOs, these are international ones, but there's so much good opportunity to present, so don't miss those. So that you can present your work either as oral papers, posters. There are so many options like physical, poster podium, and videos. And ensure to give exit exam. Now, incidentally, in Narayan Netralaya, we have the Rajiv Gandhi University exam because they are affiliated to this university. But in other places also you can give FICO. That will make you stand apart and help you learn more, because sometimes all the fellowships may not have exit exams. Then coming to the other aspect, publications, at least one case report or case series is what you should aim for. Observational and interventional series like retrospective, cross-sectional, etc. Be a part of prospective studies and try to aim for RCTs because this opportunity you will get at your institute. Be a part of reviewing articles. So your teacher and mentor may have these articles to review. Do it with them. Try to do independently so you learn the knack of writing papers and reviewing them as well. Then also you need to publish in your local and state society conference, like for us it's KOS, the Journal of Visual Sciences. Then renowned journals like DOS Times, which are read by all. And then our own AIOS official journal like IGO. More so because there are so many options in IGO like case reports, photo assays, OMO. So these are things which you can start with and eventually have reviews and write up for your mentor, with your mentor, and then you can be independent. You can also look at high impact journals like IOVS, ophthalmology, and specialty journals like for our specialty like pediatric ophthalmology and strabismus as mentioned here. Have targets at the end of your fellowship. At least one case report in peer-reviewed journals like IGO and JAPOS, retrospective studies in state societies, then national and international level, and one research project, so that at the end you are tuned to how you can go about and starting doing the same in your practice. Then the other important aspect is training. That will help train to go. So basically teach your junior fellows and postgraduates. You should take classes for them, lectures, part of workshops, teach in clinics and after routine hours. But in addition, when you're doing it, it should be done under supervision. That is somebody watching you do it, not just as a senior fellow. And then when you're competent enough, just before you're exiting, you can do it independently. Even when it comes to surgical, one surgery assisting is important. Leave my fellows going for surgery. So what I tend to do is, once a fellow has become senior, he would assist, which is normally done, but that will be still done under my supervision because I'm assisting my senior fellow to see whether she's assisting well. Then since that's because if it's not the operating surgeon, there's relative peace of mind and complication can be handled easier, taken decisions properly and managing better. So this is another fellow of mine operating, and I'm happy that this went off perfectly. And the final part is communication, which is important, how to talk to your patient. Now for us, these patients are children, so basically how to handle them. So talking to the parents to explain the problem and also the treatment helps building a good rapport, and that is very important for us as pediatric ophthalmologists. In that way, we also learn to handle unhappy parents. But very important, ask the question why when you see a particular patient. Like what the 62-year-old female came with gradual constriction of vision, underwent cataract surgery for the same problem, but this constriction did not go. She had both eyes pseudophakia with normal retina. So important, as we repeatedly say, history is very, very important. So this patient had actually cancer and had got treated. So this is very classically cancer-associated retinopathy. So if you would not have known it and you would have not taken a good history, you would have missed it. And the diagnosis is done by using an ERG. Then the other aspect of communication is right counseling and treatment goals. For example, a third nerve palsy complete. You can see no elevation, no depression in the right eye, and no adduction. All was abduction. So you need to explain to the patient what exactly is going to happen, how many surgeries are needed, so he's very clear and what he can expect and how much surgical surgeries may be needed. However, remember in our specialty, never give up because there's always a rehabilitation available. The other thing is in pediatric ophthalmology, look at the child as a whole. It could be a part of systemic disease and syndromes like Gaucher's disease, mucopolysaccharidosis, so you need to know that. And more importantly, a good coordination with other specialties like pediatrics, clinical geneticists, neurologists is a must. So finally, to end with, that fellowship is not an easy task. You will have some people throwing stones in your path. It depends on what you want to do it, build a wall or a bridge. Remember, you are the architect of your own life. Be thankful of what you get and make the best out of it because this is a fellowship and very few people get it. So enjoy your fellowship journey and have a wonderful life. Thank you very much.
Thank you, Dr. Jyoti. We just have a couple of more minutes, so just to diversify the information, Dr. Ramesh, LVP experience, any comments on how a good fellowship program can be kind of implemented?
I think one of the, is it audible?
No.
Am I audible?
Started.
Yeah, it's on. Yeah.
It's on. Anyway, I think for our field of pediatric ophthalmology and neuro-ophthalmology, three things stand out is setup of GA. Many people are still not satisfied with the cataract surgery. And the third and the most important thing is revenue. These are the three things people think about it. So in terms of demand and the requirement, I think a lot of things are there. But what I have seen, what we have seen, personally, I have seen training close to 75 fellows, is that the attitude and aptitude is the most important. It's not that they should be, very intelligent. Ultimately, what happens is their interest, their perseverance makes them the best. It's not that where do they come from, but we can train them if they have good interest. That's what we have seen. But somehow, as a country, I think we need to look at how to improve these things which are not there, because many fellows still they want to be successful in cataract surgery as well. This is one of the most important thing.
It's unfortunate the way the society is actually, and everybody comes from society, so there's nothing we can actually stop the commercialization of all this. Dr. Mahesh, anything on running a very successful and a very good neuro-ophthalmology?
So in our institute, we don't combine strabismus and neuro-ophthalmology, so I'll be able to speak only on neuro-ophthalmology. And we offer 3 months program only, short-term training. And one of the aspects which we have found is very helpful is we always rotate them in other related specialties like orbit, which are closely related, as well as orthoptics and pediatric ophthalmology for about a week each. And integration of all these specialties, even though it is short term, it is really helpful for them. And of course, they don't operate in these 3 months because it's a short term. They focus exclusively on neuro-ophthalmology.
You don't have issues or problems in getting interested candidates?
No, we don't have. We have we don't have much because it's 3 months.
True.
Okay, so
Yeah.
that is
Yeah,
a
for
catch.
3 months.
That is a
could.
catch.
Yeah.
So,
Now, Ambika, a couple of words before I invite Dr. Vidya to start the next session.
I think we have problem because it's about 18 months
Yeah.
and it's general ophthalmology with neuro-ophthalmology without any surgical specialty. Dr. Sujata was mentioning that you will have a feel-good factor at the end of the day when you finish a clinical practice of neuro-ophthalmology. That's only a feel-good factor because if it is not going to be a surgical specialty, definitely the takers are less. And in fact, we have a very good network of neurology, neurosurgery, radiology, ID, and we also have an emergency postings along with this. And we have a neurooptometry rehab program also, which is also inculcated in the fellowships. So I think it is not only in India we have this difficulty of finding a flair for the specialty. In fact, Dr. Clementine was asking, how do you get fellows for neuro-ophthalmology in India? Because it's a global problem.
I guess, true.
But I think as the specialty is so good, it doesn't matter if we don't get too many people. I mean, it's good if we get very condensed number of really interested people. So I think
True, but
We have
but
a
anyway,
fellow.
let's hope this changes. I mean, some good news to share, of course, before we invite the OP people. FICO has started neuro-ophthalmology. Unfortunately, only one person appeared for it last time, and so we had an issue. This time, we will try and push AIOS to actually make it, kind of advertise it enough so that more people apply for it. So there is now a FICO certification that is there, so people can get certified. So people who are, even short-term fellow trained, who do not get any major certificate to boast of as being good, well experienced in neuro-ophthalmology, can appear for the FICO exam and get a proper certification. And of course, FICO is now getting better and better. Dr. Grover shared the idea that probably it's going to kind of mix with international programs and probably create benchmarks internationally. So that would be very, very good from an academic standpoint. Like I said, we have now started neuro-ophthalmology FICO, which is, after a long struggle, we managed to get that. I think it's great. And again, the program is now well designed and very clear. So over, I think, next few years, we may probably start getting more people interested in this specialty. So thank you very much. Thank you, everybody, for being here. And I'll invite Dr. Vidya to now please take forward the program on oculoplasty.